So move on the second talk, and the topic of the second talk is the manage low TSH in pregnancy. And for this, I would like to call upon the stage Dr. Uzma Jahanzaib Malik. She is the Associate Professor of King Edward Medical College, and she is the member of the American Association of Clinical Endocrinology, and she is also the executive member of PES. Ma'am, please.
Okay, thank you very much. Bismillahirrahmanirrahim. Today I am going to talk about how you are going to manage low TSH during pregnancy. We get many calls from gynae department regarding thyroid dysregulation. Most of them are hypothyroid, and sometimes they do have low TSH and hyperthyroidism as well. So before going on to the talk, let's look at a scenario which you will get in OPDs. A 31-year-old lady, gravida 2, para 1, abortion 0, 17 weeks pregnant, with no previous significant medical history and no previous history of any history of thyroid disease. Now she had nausea, vomiting, palpitation. These are the usual common symptoms which occur during pregnancy as well. And she had deranged thyroid function test. On examination, her pulse was 100 per minute, blood pressure 105/65. She had warm hands, no thyroid eye signs, mild bruit, and no bruit and mild goiter. Her TSH was 0.04, that is suppressed. Her T4 is 14, which is above the upper normal limit, and T3 is 3.5. Now, what to do with that patient, and what we are going to do next? Check her free T4 levels and trap antibodies. Check her LFTs and start her on antithyroid drugs because she had suppressed TSH and high T4, and reassure her and recheck her TSH after 6 weeks. Now, anybody want to answer A, B, C option? A, C. So there's a 50% consensus. Some says A and some says C. C. In order to proceed, we must know about the thyroid physiology during pregnancy. During pregnancy, certain changes are going on in thyroid gland. The thyroid gland tend to increase in size by 10 to 15% in a normal pregnancy. There are iodine losses through kidney, and also placental loss of iodine is there. So more and more demand of iodine is there during pregnancy. Also the HCG produced by the placenta, it acts on the thyroid gland on TSH receptor with production of more and more T3 and T4, which result in the negative feedback, and physiological suppression of TSH is there during pregnancy. Also, under the influence of estrogen, more and more hepatic synthesis of thyroid binding globulins are there, as a result of which total T4 tends to increase during pregnancy. So during pregnancy, the physiological changes will lead to more and more production of thyroid binding globulins under the influence of estrogens. So total T4 will increase, HCG will increase more so during the first trimester, and under its effect, free T4 also increases and TSH is suppressed. So in all cohorts of pregnancy, the TSH is suppressed during normal pregnancy in all the population below the normal limit. And you can see that TSH suppresses more so in 10 to 11 weeks of the pregnancy, and maximum total T4 rises up to upper normal during 10 to 12 weeks of the pregnancy. So now the same scenario. So this lady did not have any features pre-pregnancy of Graves' disease, and she had signs and symptoms which were consistent with her pregnancy regarding considering the thyroid physiology pregnancy. Her TSH is mildly suppressed, total T4 is raised, and nothing to do in this patient, and no antithyroid drugs are needed. Just reassure her. So TSH, as I already said, tends to get suppressed in all the pregnancies, more so in first trimester of the pregnancy. And remember, it's ethnic specific and race specific. The Western population have set their cutoff values as per their population of TSH. That is, during the first trimester, the cutoff values are 0.1 to 2.5. Then second trimester, the cutoff values are 0.2 to 3. And in third trimester, it's 0.3 to 3. Now about free T4, if the free T4 is done by equilibrium dialysis method and ultrafiltration method, which is difficult to perform, not cost effective and laborious, in these cases free T4 is usually more reliable, but it's not widely available. The most widely available test, indirect analog immunoassays, it usually hampered by the disruption of the equilibrium, and it is has interaction with increased amount of total T4 and increased amount of non-esterified fatty acids during pregnancy. So the analog immunoassay, if they gave the trimester-specific and population-specific ranges, then you can use. If not, it's not a very reliable test. Now, what to do in our setup? We do not have that ultrafiltration assays available. We have analog assays. So you can use total T4 with specific calculation in order to find out whether the patient is having hyperthyroxanemia or not. In this case, from week 16 onwards, you can have increment of 50% in the upper normal reference range of non-pregnant range, and you can add that to the upper normal reference range and calculate whether the patient is having hyperthyroxanemia or not. So each population derive its own normative values for pregnancy using reference intervals, that is method specific and trimester specific, and is obtained from healthy pregnant population. So the low TSH during pregnancy can be physiological, as I have already mentioned, and it can be due to under the effect of HCG produced by certain conditions, for example, in molar pregnancy, in twin pregnancy, and gestational transient thyrotoxicosis. However, the pregnant patients can have hyperthyroidism due to any cause the non-pregnant patient can have. That is grave disease, gestational transient thyrotoxicosis, toxic solitary nodule, multinodular goiter, subacute thyroiditis, silent thyroiditis, thyroiditis factitia, or struma oviri. Any cause of hyperthyroidism that can cause hyperthyroxanemia in any female can cause it in pregnancy as well. However, in pregnancy, the most common are gestational transient thyrotoxicosis and Graves' disease. So we are going to discuss about these two only. So the next scenario is a 28-year-old female. She was gravida 2, para 1, abortion 0, 9 weeks pregnant. She had vomiting, weight loss of 3 kg, and she required IV hydration. She had tachycardia, tremors, no eye signs, and no bruit. Her TSH was suppressed 0.04, and total T4 is 22 microgram. That is much above the upper normal reference range. So she might be having either gestational transient thyrotoxicosis and Graves' disease. In order to differentiate between these two conditions, we can have certain clues on history and examination that how you are going to differentiate between these two. Graves' hyperthyroidism, its prevalence is 0.1 to 1% during pregnancy, and GTT, that is gestational transient thyrotoxicosis, it prevails in 2 to 3% of pregnancies. The symptoms of hyperthyroidism pre-pregnancy will be there in case of Graves' disease and not in case of gestational transient thyrotoxicosis. It will be more marked in case of Graves during pregnancy than GTT. Nausea, vomiting will be more marked in case of gestational transient thyrotoxicosis as compared to Graves' disease. Obviously, goiter, TSH receptor antibodies, and vascularity on ultrasonography will be there in case of Graves' disease, and this will not be there in case of gestational transient thyrotoxicosis. So these are the clues which help you to find out if the patient present during the first trimester of pregnancy, to which line you are going to take to the patient and how you are going to manage it. So in case of gestational transient thyrotoxicosis, the HCG level tends to be more as compared to the rest of the pregnancies, and it tends to settle down by itself towards the end of first trimester, and TSH tends to move up by itself without any treatment. So a 32 years old lady, gravida 3, para 1, abortion 1, treated for Graves' disease for last 2 years. So during pregnancy and in our endocrine OPDs, we tend to get calls from gynae obs department about the Graves' disease, which were diagnosed during pregnancy or were having previous history of Graves' disease and had thyroid dysfunction, and now how you are going to manage. She was completely asymptomatic at the time of presentation. Her T3, T4 within normal limit, and TSH was slightly depressed. So how you are going to manage Graves' disease during pregnancy? So regarding Graves' disease, it's important to mention that hyperthyroidism has detrimental effects, not only for the mother, but also to the fetus as well. The hyperthyroidism itself can lead to hypertension, arrhythmias, heart failure, stillbirth, miscarriages, intrauterine growth retardation, preeclampsia, and eclampsia. And if the mother is taking anti-thyroid drugs, she can have the side effects of these drugs, that is rash, agranulocytosis, which are rare but can happen, and liver dysfunction. Now, the thienamides can affect the fetus as well because it crosses the placenta and suppresses the thyroid function of the baby as well, leading to fetal hypothyroidism as well. In addition, since Graves' disease is an autoimmune disorder, the antibodies tend to cross the placenta and affect the fetal thyroid as well. So the fetus can have fetal hyperthyroidism, and there can be neonatal hyperthyroidism, and if anti-thyroid drugs are affecting on the fetal thyroid gland, the fetus can have hypothyroidism, and there can be neonatal hypothyroidism as well. So there can be three scenarios. The patient can present before conceiving, okay, how I would like to take my pregnancy and should I conceive or not. And if the patient presents to you during pregnancy, during the first trimester or second trimester, how you are going to manage those patients, and post-delivery, how you are going to monitor and manage those patients. So if the patient of Graves' disease comes to you in a pre-pregnancy state and she wants to conceive, you have to see whether the patient is having active hyperthyroidism going on or not. If the patient is having active hyperthyroidism going on, you have to make the patient euthyroid, but by whatever strategy is convenient for the patient, and whatever strategy is perfect for the patient through radioactive iodine ablation or neomercazole, you have to render the patient euthyroid. And if the patient comes to you in pre-pregnancy counseling and she has controlled her thyroid profile, you have to see that whether the patient is high risk or low risk. If the patient is having large goiter, she is using large doses of neomercazole and TSH receptor antibodies are high, still the patient is high risk, and you have to do definite therapy before the patient conceives. If the patient is at low risk, that is TSH receptor antibodies are low, the goiter is mild, and you can continue with anti-thyroid drugs. In the first trimester, you can switch to PTU, propionthiouracil, and in second and third trimester to neomercazole or methimazole. The true drugs which can be used during pregnancy, these are carbimazole and propionthiouracil. Propionthiouracil is usually preferred in the first trimester of the pregnancy, and neomercazole during the second and third trimester of the pregnancy. Although both can cause placenta and both can cause congenital anomalies, the anomalies associated with neomercazole are aplasia cutis, choanal atresia. Certain other anomalies are also associated with neomercazole. The anomalies are not only limited to neomercazole. PTU can cause certain congenital anomalies, especially urogenital and respiratory anomalies, but these are more so common with carbimazole, that is why than PTU. That is why PTU is preferred during the first trimester of pregnancy. So now, if the patient can present to you during pregnancy with 4 scenarios. The patient can have new diagnosis of Graves' disease. She presented to you for the first time with Graves' disease during pregnancy, or patient has pre-existing Graves' disease which is uncontrolled, or the patient had previous history of Graves' disease, she was on anti-thyroid drugs, now off the drugs and is controlled, or the patient has previous history of Graves' disease and she was previously treated before pregnancy with iodine 131 or radioactive ablation. So if the patient is having new or active Graves' disease, during the first trimester, you are going to start with PTU, switch to neomercazole, and continue neomercazole post-delivery. You have to give it the lowest possible maximum dose, and high to normal free T4 is the target, and you have to monitor the patient 2 to 4 weekly. During the second trimester, go for TSH receptor antibodies as well. Continue monitoring post-delivery. Check the baby's TFTs after the delivery as well. Thyroidectomy is a rare option, But if the patient is not controlled on any drug, and if the patient is having allergy to any anti-thyroid drugs, you can go for a thyroidectomy. So I will just take 2 minutes. You can see that the doses of neomercazole, methimazole throughout the pregnancy tends to get lower down because disease tends to get remit towards the end of the pregnancy. If the patient is having grave disease treated with anti-thyroid drug, you just have to monitor through the trimesters. And if the patient is having previous history of grave disease, hypothyroid, you have to adjust the dose of levothyroxine and monitor TRAB antibodies and fetus during the pregnancy. And so in management of grave disease depend upon whether the patient present to you at the preconception phase, during pregnancy or after pregnancy. So the summary is, if the patient present to you with low TSH, go for free T4 level. If it is normal, it's subclinical hyperthyroidism, you don't have to do anything. And if the patient is having overt hyperthyroidism, either it is grave disease or it can be due to gestational transient thyrotoxicosis, which we have to differentiate on the basis of table I have already shown, and we have to manage accordingly. Thank you very much.
Thank you so much, ma'am, for your valuable talk.